To Dr. Ajay for the kind introduction, and at the outset I thank Dr. Anjana, Dr. Mohan, Dr. Ranjit, Dr. Pradeepa, Dr. Deepa and all the dynamic team of Dr. Mohan Center. It is always an honor to come here and participate in the international conference. Thank you. Dear friends, what I'll be speaking in the next 20 minutes or so regarding the recent kidney outcome trials, which is very, very important. And now we have got the confidence of using some of the new molecules, especially the SGLT2 inhibitors, GLP-1 receptor agonists, and the MRAs in the management of diabetic kidney disease. So let us see. These are my disclosures. Dear friends, we all know about the magnitude of the chronic kidney disease and diabetic kidney disease in the causation of whether it is a mortality or whether it is a morbidity. And if you see here, 4 in 5 type 2 diabetes patients diagnosed with cardiovascular disease or CKD died of cardiovascular disease. And basically, it is a cardiovascular renal disease, not only the cardiovascular disease. And nowadays, we all know that this is a Start India trial by Dr. Rajesh Rajput, and which says that it is around 48% of people with type 2 diabetes suffer from chronic kidney disease. Dear friends, this is the most important part of my presentation. Why treat advanced chronic kidney disease if it is too late? That is the all take-home message today. First of all, the most important part is the prevent or delay the progression to the dialysis or the treatment. And you know, the people who are on dialysis, this is a really serious problem for not only for the patient, for whole family. They are suffering if the patient is on weekly dialysis or on the alternate day dialysis. Second is they prevent the progression of other complications because of the retinopathy, the blindness, and we have just seen the diabetic foot, the amputations. Then the important thing aspect is that of course we have to prevent the cardiovascular events, including the congestive heart failure or heart failure. And the most important part, once the patient is suffering from chronic kidney disease, is the quality of life suffers a lot. And of course, when the patient is on end-stage renal disease, you know the cost involved out of the pocket for the patient. Dear friends, diabetic kidney disease, we all know that there are how the kidney actually suffers. This is one of the very important thing, that there are 3 main reasons or main mechanisms by which the kidney suffers from the diabetes or hyperglycemia. That is, one of this is the metabolic involvement, the hemodynamic involvement, and the structural involvement. There are the 3 mechanisms by which a diabetes or hyperglycemia causes the diabetic kidney disease. So, what are the risk factors for the renal damage? They are always amplified due to chronic hyperglycemia, that is very important aspect, hypertension and inflammation or inflammatory cytokines. So how do we actually manage the diabetic kidney disease these days? This is very, very important. If you see here, the most important, the base of the management of chronic kidney disease is definitely we have to reduce the salt intake for the hypertension management, the regular exercise or physical activity. If patient is on alcohol, please reduce the alcohol intake. And of course, the most important is to maintain the optimal weight. And of course, if patient is smoking, that is very, very dangerous and risky in diabetic kidney disease. And of course, we have to have the individualized or personalized diabetes management. Tier 2, the second aspect of the diabetes management, diabetic kidney management, is the RAS blockade, which is the most important. SGLT2 inhibitors now comes the ahead of over and above any other molecule for the management of diabetic kidney disease. And if patient is already having dyslipidemia, of course, statin is the drug of choice for that. And then the recent evidence suggests to us regarding the GLP-1 receptor agonist in the if the patient is already having the atherosclerosis cardiovascular disease, and then we have the non-steroidal mineralocorticoid receptor agonists and the MRAs, and of course if there are need, then intensive management is also needed. So these are the kidney outcome trials. These are the things, and I'll go one by one. I'll go very quickly, but the last one is the take-home message. So first important thing regarding the advanced clinical trial, and this advanced clinical trial for the first time actually establishes the role of the glycemic management, especially when you are using the glycoside. And here, if you see here, whether the HbA1c reduction to the tune of around 6.5% or reduction in micro and macrovascular complications regarding to the tune of around 10% reduction. So glycoside for the first time gives us the confidence that yes, glycemic control is the hallmark for not only the reduction of the glycemia, but also reduction in the micro and macrovascular complications in diabetes. So what happens once we see the micro and macrovascular complication, of course glycemic management or glycemic control is the most important thing. Now regarding the albuminuria, if you see the prevention of albuminuria it is reduction to the tune of around 30%, and to the prevention of end-stage renal artery disease, if you see even 65% reduction by just a good glycemic management, especially in this study it is a glycoside. So what actually this study suggests to us that glycemic control is the most important part, and not only that it reduces the micro and macrovascular complication, but also reduces the albuminuria risk and the ESRD risk. Then the SGLT2 inhibitors, I told you this is one of the most promising molecule for management of type 2 diabetes, for diabetic kidney disease, for reduction in the cardiovascular disease also. So there are three important trials I came here with you: the CREDENCE trial, the DAPA-CKD trial, and EMPA kidney trial. Let us see the CREDENCE trial. It is the trial between canagliflozin versus placebo, and these are the patients taken are the type 2 diabetes with evidence of kidney disease. And if you see here, whether the major acute cardiovascular events or the kidney points, the canagliflozin group actually had a lower risk of kidney disease progression or cardiovascular events as compared to the placebo group, and this clearly suggested to us in the CREDENCE trial. If you go for the subgroup analysis, whether the primary composite endpoints or whether the renal specific points, if you see this forest plot, this is all shift to left. So that also suggests that whether the primary endpoints regarding the end-stage renal disease, doubling of serum creatinine, or renal or cardiovascular death, I think this is the canagliflozin is superior as compared to placebo. So even it affects on the albuminuria and estimated eGFR, this is very, very useful. So canagliflozin for the first time significantly showed us that it reduces the major cardiovascular events, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke were consistently reduced. Now the second clinical trial, the DAPA-CKD trial, and which is again dapagliflozin versus a placebo, and this is all patients of chronic kidney disease were taken, included in this clinical trial, and both if you see there were the primary composite endpoints or renal composite endpoints, the sustained decline in the estimated GFR for at least 50%. End-stage kidney disease or death from renal or cardiovascular disease was less frequently showed in the dapagliflozin group. If you see if you see here in the this is placebo versus the DAPA, and definitely it is very, very superior. So DAPA 10 milligram per day was tested in the patients here. The primary endpoint was a composite of more than 50% eGFR decline. The trial aimed for around 90% power to detect 22% relative reduction with around 681 primary renal events, and all points were showed much better in the dapagliflozin group. Now this is again a very recent study. This is an EMPA kidney study, which is again EMPA versus placebo, and all patients included were the chronic kidney disease. And again, if you see here, the comparison of EMPA versus placebo, the progression of kidney disease or death from cardiovascular disease, EMPA resulted in a lower risk of disease progression or death from cardiovascular death. Primary outcome, if you see here, whether diabetes, estimated GFR or urinary albumin, UACR, if you see here, again in the forest plot, they have shift to left. That shows a significant effect by the EMPA as compared to placebo. Again, change from baseline here, if you see here, EMPA is better than placebo. So what this study suggested to us, EMPA reduces the kidney progression or cardiovascular death over a median of 2-year follow-up. This is a EMPA kidney 2-year study. Benefits were consistent across all GFR groups, not only the higher GFR or the medium GFR, but all the GFR groups, the benefits have been shown, and hospitalization risk was lower, but no significant difference was seen in the heart failure hospitalization. This is in the EMPA kidney. Then the CANVAS program. CANVAS program was a report of the 2 randomized clinical trials with the patients with type 2 diabetes at the risk of cardiovascular disease, and first time this CANVAS study has shown again, if you see death from cardiovascular disease, fatal, non-fatal myocardial infarction, fatal or non-fatal stroke, again, if you see all the shift to left, that also showed a beneficial effect of canagliflozin. So it significantly reduces the risk of kidney disease progression, and it showed a eGFR decline. Mean UACR was 18% lower with canagliflozin here. This is the very recently, just I think 1 month back, this study was published, and this study, DAPA-TAVI study, for the first time that people thought that TAVI is the gold standard procedure, aortic valve replacement. But if in these patients, this is the first trial testing the SGLT2 inhibitors in valvular heart disease for the first time, specifically in severe aortic stenosis and post-TAVI. So SGLT2 inhibitors were given in the post-TAVI patients, and what it showed here, it contradicts the old notion that TAVI fixes everything. No. Expand the role of SGLT2 inhibitors to a new high-risk elderly population, often underrepresented in the clinical trials. So dear friends, even SGLT2 inhibitors have been useful in the post-TAVI patients, and this is a subgroup analysis here, and the clinical takeaway clearly showed us that it supports the routine use of dapagliflozin post-TAVI. It reinforces the SGLT2 inhibitors as fundamental therapy across the heart failure phenotypes, and encourages the physicians or clinicians to avoid therapeutic inertia not to use the SGLT2 inhibitors in most of the patients. So this is one of the very recently trial, and the debate is always there. This is Dr. A.K. Singh's presentation and publication, and for the first time he has shown the comparison between DAPA and EMPA. So this is one of the first aspect, is the absolute risk reduction with DAPA versus EMPA in heart failure, reduced ejection fraction. And if you see here, here's a 39 CV death, and this is a 52 less CV death or heart failure hospitalization. Both 14 in the cardiovascular deaths, 5 in the EMPA. So this is a comparison. You can have a presentation in your publication, which is there in the expert opinion in pharmacotherapy publication. You can take the photograph and take the use of comparison of DAPA versus AMPA. Again, this is the in CKD. If you see the absolute risk reduction with DAPA versus AMPA, again 29 points here as compared to 21 in the primary renal composites and the AMPA. And again, if you see, there is a good comparison, but most of us, for us, the clear take-home message is the almost it is a molecular or it is the drug effect of the SGLT2 inhibitors. Then the important aspect is the mineralocorticoid receptor agonist. This is the MRAs and this is a Finrinicon outcome trials and two very important milestone trials, Fidelio CKD as well as the Figaro DKD. And just see here in the Fidelio DKD trial, this is Finrinon versus placebo, and the outcome is again very favorable here. The treatment with Finrinon resulted in lower risk of chronic kidney disease outcomes and cardiovascular outcomes. Again, this is Finrinon has shown not only the good reduction in the chronic kidney disease, but composite cardiovascular outcomes, whether it is a cardiovascular death, myocardial infarction, stroke, or heart failure, hospitalization in CKD and type 2 diabetes, regardless of heart failure. This is first point. Second, kidney composite outcomes. Kidney failure more than 40%, eGFR decline or renal death showed consistent benefits. So again, this is very important. The Finrinon can be used over and above your heart failure management, which you are already doing. Finrinon versus placebo, this is Figaro DKD. Again, the Finrinon treatment was superior with regard to the primary composite outcome of death from cardiovascular cause, non-fatal myocardial infarction, non-fatal stroke or hospitalization from heart failure. Again, I think this is Finrinon is again a very, very useful molecule in management of diabetic kidney disease and heart failure in particular. Then the leader trials, again very important milestone trials. GLP-1 receptor agonists have shown the very good effect on the diabetic kidney disease, not only the cardiovascular aspect, but also in the chronic kidney disease. So, of course, this is the first clinical trial. The leader trial has shown the liraglutide reduces the major cardiovascular events, all-cause mortality was reduced, and incidence of all again non-fatal myocardial infarction all have shown. Then the Rewind trial. This is again a dulaglutide trial, has shown very positive clinical trial. Here, this Rewind clinical trial, dulaglutide 1.5 milligram versus placebo, and if you see here the cumulative effect here, it shows the reduced major cardiovascular events over a median of 5.4 year follow-up. All-cause mortality was similar, of course, but gastrointestinal adverse effect was significantly more frequent. We all know that GLP-1 receptor agonist has the gastrointestinal side effects. Now, this is the very recent clinical trial, two trials, the FLOW trial and the SELECT trial. The FLOW trial represents the first of trial to examine the kidney outcome, and SELECT trial reported the significant reduction of cardiovascular events in the persons who were overweight or obese. So this is the FLOW trial. This is a comparison between the semaglutide 1 milligram versus placebo. Primary endpoints were taken as a component of kidney failure here, 50% decline in the eGFR. So after a planned interim analysis, they indicated a significant treatment benefit by the semaglutide here for the first time, and it is consistent. If you see here, interim analysis showed 24% reduction in the primary endpoint, 21% kidney-specific endpoints, 18% first major cardiovascular event, and 20% reduction in the all-cause mortality. SELECT trial again, it is the higher doses of semaglutide versus placebo. So this also showed after a mean follow-up around 39 months or around 40 months, 20% lower risk of cardiovascular events were observed by the semaglutide at the high doses of 2.4 milligrams. So implication for the first time, it has shown that kidney and CV production is definitely with GLP-1 receptor agonist. It is a kidney protective therapy, and it is important benefit is substantial weight loss. The weight loss is the primary thing, of course. In the SELECT trial, again, it showed the kidney protection. It facilitated the weight loss, and strong rationale for the further studies, of course. So all the studies are in front of you. All studies are in the favor of using the SGLT2 inhibitors and the GLP-1 receptor. This is the one very important slide which says that in spite of using everything, all therapies in chronic kidney disease, is still residual risk, whether the renal study, IDNT, Fidello, Credence, DAPA and EMPA, there is a residual risk. Still, we need the better molecules and better therapies. So the 5 pillars are there for the management of chronic kidney disease. We all learned by the clinical trials that metabolic control or glycemic control is the most important aspect in management of CKD or DKD. SGLT2 inhibitor, whether EMPA, DAPA or CANA, or even GLP-1 receptor agonists are useful. Antihypertensive management by the RAS inhibitors, whether it is ARB or ACE, they are again very important. Then the RAS blockers and the sodium bicarbonate. Sometimes we may need the soda bicarb. So this is my last take-home message. Mechanistic insight: SGLT2 inhibitors reduces the glomerular hyperfiltration and oxidative stress. GLP-1 receptor agonist as anti-inflammatory, anti-fibrotic, endothelial protection, and RAS inhibitors. What is the clinical practice guidelines? SGLT2 inhibitors, GLP-1, RAS blockade, and please avoid dual RAS inhibition. We don't need, and all the on-target and nephron D clinically show that we don't need dual RAS inhibitors. On case-based applications like type 2 diabetes with albuminuria, EGFR, start SGLT2. If patient is having obesity with DKD, add GLP-1 receptor agonist. Patient is CKD stage 4 with hyperkalemia, RAS plus potassium binder is the drug of choice. So thank you very much for the patients listening, and I think I have covered most of the clinical trials for all of you.